Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 565 of our pharmacotherapy series, which majors in sleep disorders. The next case reads, BAT, a 42-year-old woman with a 5-year history of hypothyroidism and a 2-year history of hypertension and chronic lower back pain, was just transferred from the intensive care unit into a medical unit. Her cardiac status is considered stable 2 days after a myocardial infarction, abbreviated as MI. She is 5 feet 9 inches tall and weighs 72 kilograms. She is receiving aspirin 81 milligrams, enteric-coated, levothyroxine 112 micrograms, and felodipine 10 milligrams, all taken by mouth 1 hour before breakfast every day. Her main complaint is insomnia, including difficulty falling asleep, difficulty maintaining sleep, and early morning awakenings. BAT reports insomnia for 6 weeks before admission, which worsened during the hospitalization. What type of insomnia does BAT have, and how might the insomnia affect her health?
Reverse the blur effect. So in this case, if let's say I want to blur this person's shirt, then I could go with rectangle, then I reverse it, and then I just adjust it until his t-shirt is blurred. With this, if I want to blur the camera, then I can just move it like this, and I can blur the camera. Just play around with either the circle shape like this, can make it.
BAT's insomnia is considered chronic because she experienced it for 6 weeks before hospital admission. It is severe because it involves difficulty falling asleep, maintaining sleep, and early morning awakening. Careful monitoring and effective treatment of BAT's sleep disturbance is crucial. Studies show disrupted sleep can increase the risk of another adverse cardiac event owing to worsening autonomic instability and poor perfusion to the myocardium. Because normal sleep moves through all the stages of NREM and REM in a continuous cycle, a patient deprived of continuous sleep may not receive sufficient time in each sleep stage. When stage 2 is diminished, muscles have insufficient opportunity to rest and rejuvenate. If NREM stages 3 and 4 are eliminated, immune function and the healing process can be disrupted. If REM sleep is deprived or excessive, neurotransmitter function may be altered and physiologic homeostatic processes can be disrupted. What individual drug or disease state factors should be assessed in BAT before developing a treatment plan?
Reverse the blur effect. So in this case, if let's say I want to blur this person's,
it calls for thoroughly evaluating all concomitant conditions and the type of insomnia in each patient. Numerous medical disorders and primary sleep disorders are associated with difficulty falling asleep and maintaining sleep. First, BAT should be assessed for sleep apnea, because untreated sleep apnea is a known etiology of cardiac disease and hypnotics can be dangerous in untreated sleep apnea. Second, BAT's pain management should be assessed for optimal efficacy. Acute post-myocardial infarction pain adds to BAT's chronic lower back pain. Of patients with lower back pain, 50% experience chronic poor sleep patterns. Third, BAT was just transferred out of the ICU. Sleep deprivation in an ICU is common and is attributed to the continuous lighting, noise, and constant interventions. Sleep deprivation may prolong or worsen a disease process through diminished natural killer cell activity and decreased stages 3 and 4 of NREM sleep, when healing occurs. Medications also may be contributing to BAT's insomnia. Levothyroxine can overstimulate the CNS if given in excessive doses. BAT's thyroid status should be re-evaluated to ensure appropriateness of the thyroid dose, especially considering her post-myocardial infarction status. Calcium channel blockers have been associated with occasional sleep disturbances. Therefore, felodipine should be evaluated as a potential contributing factor. Another clue to a possible cause of BAT's sleep problem is her description of early morning awakening, which could be related to hospital activity during these hours or to the presence of a major depressive disorder. BAT requires psychiatric evaluation to rule out depression, which occurs in about 1/3 of patients after a myocardial infarction. In general, patients with chronic illnesses are at increased risk of experiencing major depression, which typically presents with insomnia or hypersomnia. Interestingly, medical outcome studies of other chronic illnesses, cardiovascular, pulmonary, renal, neurologic disease, show a high prevalence of sleep disturbance even in those not suffering from depression. Chronic insomnia related to multiple causes can be resistant to treatment. However, treatment of underlying causes increases the likelihood of insomnia resolution. BAT's pain is now under control, her levothyroxine dose is appropriate, and felodipine-induced sleep disturbance, sleep-disordered breathing, RLS, and PLMS have all been ruled out. A psychiatric evaluation finds that BAT does not have major depression, but she is anxious about life after a heart attack. She meets criteria for primary insomnia and adjustment disorder with anxiety. She continues to have trouble falling asleep and staying asleep. She will be discharged in 2 days. The psychiatric consultation suggests an adjunctive medication with anxiolytic properties that may also help with sleep. Which hypnotic is best for BAT, considering her individual clinical characteristics?
Reverse the blur effect. So in this case, if let's say I want to blur this person's
The ideal hypnotic for BAT should act quickly and continue working throughout the night to provide her with uninterrupted sleep. A hypnotic that is not metabolized in the liver would have a lower potential for drug interactions and lessen the opportunity for systemic accumulation. If daytime drug concentrations are needed to calm anxiety, however, a hypnotic with slowly eliminated active metabolites may be desirable. When considering available hypnotic medications, differences in pharmacodynamic and pharmacokinetic properties should be considered. Onset of effect is related to lipophilicity, receptor binding affinity, and T marks. In further discussion with BAT, who prefers to try cognitive behavioral interventions for anxiety reduction and sleep induction, temazepam 15 mg at bedtime is prescribed on an as-needed basis. BAT will be monitored regularly as an outpatient for efficacy and tolerability. As BAT is preparing to leave the hospital, her daughter expresses concerns about the potential for physical dependence on temazepam and the risk of BAT becoming an addict. How would you respond to her concerns?
Reverse the blur effect. So in this case, if let's say I want to blur this person's
A benzodiazepine hypnotic that is non-selective is preferable in BAT because of the need for anxiolytic properties in addition to hypnotic efficacy. Non-benzodiazepine hypnotics are not effective anxiolytic agents. The pharmacodynamic and pharmacokinetic properties of triazolam have already been presented. Its rapid onset is an advantage for BAT. However, the duration of action would not be sufficient to help BAT stay asleep. In addition, it should not be used for longer than 7 to 10 days because of the greater potential for adverse effects with prolonged use and the possibility of significant rebound insomnia on withdrawal. BAT may require a hypnotic for more than 7 to 10 days, which is the maximal duration for triazolam use. Flurazepam induces sleep within 15 to 45 minutes during chronic dosing. On the first night of use, however, flurazepam does not induce sleep as well as triazolam. It has intermediate fat solubility, but depends on the plasma concentrations of its metabolite, N-desalcyl-flurazepam, for most of its activity. N-desalcyl-flurazepam concentrations take approximately 24 hours to accumulate and induce sleep. Studies show flurazepam maintains efficacy in sleep induction for at least 30 days. N-desalcyl-flurazepam has weak receptor binding affinity and a long half-life, resulting in gradual elimination and little chance for rebound insomnia. N-desalcyl-flurazepam can accumulate during chronic dosing and affect daytime cognition in some patients or compete for hepatic metabolism, resulting in altered levels of other hepatically metabolized medications. BAT has difficulty moving around during the day because of her chronic lower back pain, and over-sedation from accumulation may impair her daytime functioning. Flurazepam is infrequently used because of the risk of next-day impairment. It is useful to explore other options. Similarly, quazepam, having an extended half-life and potential for drug accumulation, would not be an optimal agent for BAT. Temazepam takes 1 to 2 hours to induce sleep. It has moderate fat solubility, similar to N-desalcyl-flurazepam, but it has a longer dissolution time. Temazepam takes 1.5 to 2 hours to reach peak plasma concentrations. Temazepam's longer dissolution time is caused by its large drug particle size in a gelatin capsule. A potential advantage for using temazepam in BAT's case is its lack of hepatic oxidative metabolism and intermediate duration of action of 8 to 12 hours. It does not interfere with the metabolism of other hepatically metabolized drugs, and it does not accumulate, minimizing the potential for daytime impairment relative to flurazepam. The long onset of action may be of concern, although BAT could take the drug an hour before bedtime to optimize timing for sleep. For BAT, the most appropriate choice is temazepam. Of the 5 approved benzodiazepine agents approved for insomnia, temazepam's advantages are intermediate duration of activity that would keep her asleep throughout the night, anxiolytic benefit, and low risk of daytime impairment owing to no known active metabolites. Fear of dependence and addiction to medications is a concern among the general public. Television station, medical experts, and popular magazine, health sections, while providing information, may increase the potential for confusion, erroneous impressions, and misinformation. For healthcare practitioners, it becomes even more crucial to provide sound drug information in common, easy-to-understand terms. An example of the practitioner's response may be, "I'm glad you have expressed a concern. It gives us a chance to discuss temazepam therapy before your mother leaves the hospital." Temazepam has been prescribed for a medical reason, to improve your mother's sleep and to aid in her healing process. One therapeutic benefit of temazepam is an 8-hour duration of effect. Your mother will be able to sleep throughout the night so that she is well rested during the day. It also may decrease her anxiety over not sleeping, and that puts less stress on her heart. The possible side effects of temazepam include sedation, unsteadiness, and dizziness. She should let her doctor know if she experiences any adverse effects. Right now, it is unclear how long your mother will be taking temazepam. Duration of therapy needs to be assessed on an ongoing basis. If your mother takes temazepam every night for more than 4 weeks, 2 things could happen. A. She may develop a tolerance and it may not help her sleep anymore. Or, B. Her system may develop a dependence in which she may have worse insomnia if she does not take it. The primary concern is not addiction but the possible dependence. This means your mother should not change her dose or stop on her own. Any changes in dose or stopping must be done slowly and with her doctor's involvement. These 2 scenarios do not always occur and are not likely because your mother will be taking it on an as-needed basis. If one or the other does happen, some other intervention may be tried to help with her sleep, or the temazepam dose can be gradually decreased to prevent withdrawal problems. It is important to advise your mother to avoid alcohol, and report any decrease in effectiveness or any adverse effects to her healthcare practitioner. Patients taking benzodiazepines for longer than 1 year tend to be older, medically ill, and chronically dysphoric and have panic disorder or chronic insomnia. Most chronic use appears to be medically appropriate and does not lead to dose escalation or abuse. Among chronic dysphoric patients, the indications are less clear, and dose escalation is noted sometimes without notable therapeutic benefit. Benzodiazepine hypnotics rarely are taken alone for pleasure and generally are not likely to be abused. Among substance abusers, however, they frequently are taken as part of a polysubstance abuse pattern by alcoholics and narcotic, methadone, and cocaine users. In these groups, abuse is highly prevalent. Benzodiazepines are used to augment euphoria among narcotics and methadone users, to decrease anxiety and withdrawal symptoms among alcoholics, and to ease the crash from stimulant-induced euphoria among cocaine users. Physiologic dependence on benzodiazepines, resulting in a withdrawal and abstinence syndrome, develops usually after 2 to 4 months of daily use of the longer half-life benzodiazepines. Shorter half-life benzodiazepine use can result in physiologic dependence earlier, that is days to weeks, and may be associated with more withdrawal problems. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 566.